If anyone, and I mean anyone, has told you to just live with painful sex, recurring UTIs or UTI like burning, or waking up every single night to pee because that's just being a woman, my mouth is on the floor. Absolutely not. No more shrinking, no more pink washing your pain, no more that's normal thrown at you like a consolation prize. If it hurts, burns, wakes you up, or makes you dread sex or bathrooms, it is not normal. It is a signal. And signals deserve real care. Let me say the quiet part out loud. I see you clenching your jaw during sex because penetration stings or feels like sandpaper. I see you scanning every room for the nearest bathroom because there's pressure, that sudden gotta go urgency that hijacks your day, the drip after you think you're done, the burning that shows up like clockwork after intimacy, the culture's negative, but it still feels like a UTI spiral, the leaks when you sneeze or deadlift, the dread you feel when someone you love reaches for you because your body has learned to equate intimacy with pain. And that 2 a.m. loop up again, half asleep, shuffling to the bathroom, whispering, "Why am I up again?" This is a neighborhood of symptoms, and you have been told to buy a house there and be grateful. Are you kidding me? You are not broken. You are not too sensitive. You are not failing at womanhood because your body is throwing up flares. You've been undertreated. Dismissal is not a diagnosis, and it sure as hell isn't a treatment plan. What you're experiencing has mechanisms, and mechanisms have solutions. This is not a shame episode. This is a solutions episode. We are going to talk about this in plain English, no medical mystery theater, no jargon for the sake of sounding smart. Here's what I already know about you. You want the facts, you want the science, you want results. Same, and you deserve them delivered with respect for your reality, not with an eye roll and a pamphlet. So here's the promise I'm planting right now. Painful sex, recurrent UTIs or UTI-like symptoms, and night peeing are often connected. They're not random punishments or proof you're fragile. They're a system talking. When you understand the map, pelvic floor behavior, tissue health, bladder signaling, sleep, and habit patterns, everything starts to click. And the first steps to relief, they are shockingly practical. The minimum effective dose kind of practical. Tiny shifts, you can actually do that. Start changing the way your body feels this week while you line up the fuller, evidence-based evaluation you deserve. I am protective of you. I am outraged for you. And I am telling you with my whole chest that there is a path out of this. We're going to draw the safety lines, translate the science, and give you an action plan. No more normalizing suffering. No more whispering in bathrooms. You get to feel safe in your own body. Let's freaking go. Here's the part that makes me want to flip a table. We have built an entire medical culture that treats women like small men. Take the male template, shrink it, pink it, and call it a day. And guess where pelvic symptoms go in that system? Right into the cracks between urology and gynecology. Between it's probably anxiety and your labs look fine. You show up with burning after sex, urgency that hijacks your meetings, waking at 2 a.m. to pee, and the response is a shoulder shrug with a side of condescension. Are you kidding me? Let me translate the gaslighting because I know you've heard it. Drink more water. It's just stress. Totally normal. After babies. Use lube. It's aging. Take antibiotics again. Your culture was negative, so can't be a UTI. Try relaxing. Kegels. You're overthinking it. That is not care. That is a checklist to get you out of the room. Dismissal is not a diagnosis, and it sure as hell isn't a treatment plan. And the cost? It's not theoretical. It's your life. It's the way you tense when your partner reaches for you and you fake a yawn because dread sits in your throat. It's scanning every venue like a security guard for the fastest route to a bathroom. It's waking at night again and again until your sleep shatters into crumbs. It's canceling workouts because you're afraid of leaking. It's the quiet, corrosive belief that your body's betraying you. So you start playing smaller at work, at home, everywhere. Relationships strain, confidence erodes, and you start bargaining with pain like it's a roommate you didn't choose. Here's the truth bomb. This does not just stay the same. Chronic sleep disruption rewires your nervous system to be jumpier, more reactive, more pain sensitive. Translation: the more nights you wake to pee, the louder your bladder's alarm system gets. Chronic pain, it trains your body to guard hello, pelvic floor clenching, which creates more pain and more urgency, avoiding sex to avoid pain. Totally understandable. And it can increase fear and muscle tension, which makes the next time worse. And the antibiotics merry-go-round, repeated courses for UTI-like symptoms without a confirmed bacterial cause can mess with your microbiome, set you up for yeast, and make real infections harder to treat. This is a slope, not a flat line. So we draw a line in the sand right here. You want the facts, you want the science, you want results. Same. Our standard in this space is evidence plus translation, mechanisms that make sense, and exactly what that means on Monday morning. Because your symptoms have mechanisms, pelvic floor tone that's stuck on tissue changes that make everything raw, bladder signaling that's been trained to overreact, sleep and habit patterns that keep pulling the fire alarm. Mechanisms have solutions, practical, testable, minimum effective dose solutions that reduce pain, protect your sleep, and rebuild trust with your own body while you get a real evaluation. We are done being pink-washed and patted on the head. You deserve care that treats you like a full human, not a scaled-down man. Let's freaking go. Let's draw the map, because once you see how close everything lives, the mystery starts to dissolve. Picture a tiny neighborhood the size of your palm. In that cul-de-sac, you've got your bladder, a balloon that stores urine. The urethra is the little straw that lets it out. The vagina is right next door, sharing a fence line. Underneath all of it is a sling, your pelvic floor muscles, like a hammock stretched from your tailbone to your pubic bone, holding organs, helping you stay dry, coordinating with your core. Wrapped through and around that hammock is connective tissue, think scaffolding and saran wrap that gives everything shape. And threading through the whole block is the wiring nerves that carry sensation and, hey, we need to pee messages to your brain. Everything is close. Everything talks. So when one house throws a rager, the bladder lining gets irritated, the urethra gets inflamed, the vaginal tissues get raw, or the pelvic floor clamps to protect you, the whole neighborhood hears the music. That's why symptoms bundle. Irritation in the urethra can feel like burning at the vulva. A clenched pelvic floor can make your bladder scream urgent, even when it's barely got anything in it. Dry, fragile vaginal tissue can make penetration sting, and then, surprise, your bladder feels pressure and you're up at 2 a.m. Again, it's not random. It's a group chat where one frantic text wakes everybody up. When I say UTI-like symptoms, here's normal person speak. Urgency, the gotta go now sensation. Frequency, you're peeing way more often than usual. Burning or stinging with or after urination, bladder pressure like you're sitting on a golf ball, and sometimes pelvic ache. Sometimes that's a true bacterial infection. Sometimes your culture's negative and it still feels exactly like one because the bladder lining and nerves are irritated or the pelvic floor is on high alert. The feeling is real either way. The cause is different, and that difference matters for the fix. Let's talk about that hammock, your pelvic floor. It's not just tight or weak. It can be strong in some ways and still overactive or uncoordinated. Translation, it can be stuck a little on, guarding like a bodyguard, which makes penetration hurt and sends fake urgent signals to your bladder. Or it can be under-supported and tired, which makes leaks more likely, so you clench harder to compensate, and boom, now you've got both urgency and pain. This is why Kegels for everything backfires for so many women. If the system is gripping, more squeezing doesn't help. Learning to release, coordinate, and then build support is the play. We'll get there. Quick self-sort so you can start seeing your pattern. If it's mostly pain with sex, where is it? Is it sharp or burning at the entrance, like sandpaper? That often points to tissue sensitivity plus a guarding pelvic floor. Is it a deep ache with certain positions? That can be pelvic floor tension and how the uterus or bladder sits. If it's mostly bladder urgency, do you go small amounts all day, just in case, and still feel pressure? That's bladder signaling plus pelvic floor guarding. If it's mostly nighttime waking, are you up 1, 2, 3 times and barely peeing? That points to trained signaling and nervous system arousal playing tag with your bladder. And if you're checking multiple boxes, welcome to the neighborhood. Overlap is not a fail, it's a clue. Here's the headline I want stamped in your brain. Painful sex, UTI-like symptoms, and night peeing often share the same block. Treating them like separate planets means you miss the street light that controls the whole intersection. When we map the connections, tissues, muscles, nerves, habits, we stop guessing, we stop blaming ourselves, and we start making moves that calm the neighborhood down for real. Let's freaking go. Okay, now that you can see the neighborhood, we draw the safety lines in wet cement. There are moments when we do not self-diagnose, we do not crowdsource, we do not wait it out, we get care now. Fever or chills with urinary symptoms? Go. Flank or back pain under your ribs, especially with fever or nausea? Go. Vomiting or you can't keep fluids down? Go. Visible blood in your urine? Go. You're pregnant and having any of this? Go. Severe, sudden pelvic pain that makes you double over? Go. Those are not see if it passes situations. Those are urgent evaluation situations, non-negotiable. For everything else, stop guessing and sort it like a pro. One-off infection. Symptoms start clearly. You feel awful. Culture confirms bacteria. You get an antibiotic that matches the bug and the whole thing resolves. Great. Now, recurrent infections. We're talking 2 culture-confirmed UTIs in 6 months or 3 in a year. That is not, here's another random antibiotic. That's what's the pattern and what's the plan? Are these showing up after sex? Is your bladder not emptying fully? Are tissues dry and fragile? Do you have a stone history or new diabetes? Mechanisms, not mystery. And then there's the maddening bucket, persistent symptoms with negative cultures. Burning, urgency, pressure, but your test says no growth. That can be bladder lining irritation, pelvic floor overactivity, urethral syndrome, hormone-related tissue changes, even chemical irritants from soaps, wipes, bath bombs. The feeling is real. The cause is different. So the fix must be different. Why take another antibiotic is not always the answer. Let me translate the science in normal person speak. First, resistance. The more we throw random antibiotics at symptoms without proof of bacteria, the easier it is for the real bugs to learn ninja moves and stop responding. Second, microbiome chaos. Antibiotics don't just hit your bladder. They can wipe out your good vaginal and gut bacteria, which protect you. And then yeast throws a party, hello, itching, discharge, and more irritation that feels like a UTI. Third, collateral damage. Antibiotics can inflame an already irritated bladder lining, so you keep feeling infected even when you aren't. Bottom line, if cultures are negative or this keeps boomeranging, the answer is not more of the same. It's better targeting. Here's your script at the doctor, and you say it with calm authority because you are the CEO of your body. I'd like a urine culture, not just a dipstick. If positive, which organism is it and what antibiotics is it sensitive to? What's our recurrence plan if this happens again? If negative, given my symptoms, what's our next step beyond antibiotics? Can we look at tissue health, do a pelvic exam, check post-void residual to see if I'm emptying, review bladder irritants, and refer me to pelvic floor physical therapy if needed? If you're peri or postmenopausal, can we discuss local vaginal estrogen for tissue health? You can also say, if this keeps recurring, I'd like a referral to urogynecology or urology for a thorough workup. You are not being difficult. You are being appropriately thorough about your health. Clear symptoms plus clear requests equals a clear plan. You want the facts, you want the science, you want results. So you ask for the data, the culture, the mechanism, what's actually driving this, and the map for what's next if plan A doesn't fit. That is how we stop the spiral, protect your sleep, and get you real relief. We're done with guess and gut it out. You deserve a real evaluation because the treatment depends on the cause. Let's freaking go. Here comes the truth bomb that had my mouth on the floor the first time I really heard it. Tight can feel like weak. Read that again. So many of you have been told by well-meaning friends, by the internet, by rush providers, do Kegels, squeeze more, clench harder, as if more on is the answer to every leak, burn, and bolt of urgency. Are you kidding me? If your pelvic floor is already guarding, stuck, partially contracted because pain or fear trained it to live there, more squeezing is like telling a cramp to cramp harder. That's not strength. That's a spasm with a PR agent. Let's map the cycle in normal person speak, because once you see it, you can break it. Pain or fear shows up. Maybe penetration burned last time. Maybe you leaked at the gym. Maybe your bladder barked at you in the checkout line. And your body does what bodies do. It protects. The pelvic floor clenches. Guarding feels smart in the moment, but clenching reduces blood flow. Less blood flow means less oxygen, more acidity, and nerves that get irritated and louder. Louder nerves send bigger danger and gotta go signals. You feel more pain and more urgency, so you guard more. Round and round. Pain creates guarding. Guarding fans the pain and urgency, and the alarm system gets so jumpy it goes off when the wind blows. You cannot out-Kegel an alarm. Now connect it to sex, because I know this is where the shame sprints in. Painful penetration is not in your head. It is in your tissue and your muscles and your nerves. If the muscles at the entrance won't lengthen and let go, penetration feels like sandpaper and fire. If you've got scar tissue from a tear, an episiotomy, a birth, or even pelvic surgeries, that tissue can be stiff and less elastic. If dryness or inflammation is on board, hello hormone shifts, infections, or irritants, the skin is more sensitive and the nerves are already lit. Your brain remembers pain. It anticipates. It tells the body to brace before there's even touch. So you clench more, blood flow drops more, and now it hurts faster. That is a loop, not a failure. And loops can be retrained. Urgency rides the same track. When that hammock of muscles is guarding, it can't coordinate the normal hold and release timing with your bladder. Instead, your brain gets false urgent messages. Go now, even if there's barely anything in there. You start just in case peeing, which teaches your bladder and your brain to settle for tiny volumes, which shrinks your comfort window, which makes the alarm even touchier. Trained signaling, not weak willpower. A clenched floor plus a jumpy alarm equals you living 10 feet from a bathroom. So what's the move? You do not power through. You rewire. The fix often starts with release, not squeeze. Coordination, not brute force. Think of it like learning to exhale after holding your breath for too long. We retrain the downshift. Slow, 3-6-0-degree breaths that let your ribs expand, your belly and sides soften, and the floor drop like an elevator, not yank like a garage door. We pair that with gentle lengthening positions that tell your nervous system you are safe. And when you're ready, targeted therapy, pelvic floor physical therapy that can help with manual release, scar mobilization, biofeedback for coordination, and a graded plan back to intimacy without bracing. Lube that actually protects tissue, addressing dryness and inflammation. And if you're in the hormone change seasons, tissue support that brings resilience back on board. We build hold after we earn release. We add strength only when the system can lengthen and let go. Here's your mantra. If you're clenching to survive the day, your pelvic floor is stuck on, and the first win is teaching it off. 2 to 5 minutes, a couple times a day breathing, softening, letting the floor drop with your exhale, practicing not racing to the bathroom at the first whisper of urge, but pausing, breathing, and walking on your terms. Minimum effective dose, repeatable, powerful. This is not about being tougher. This is about being coordinated and safe in your own body. And the second you feel that first wave of relief, oh my God, I can let go. You will know we are on the right track. Let's freaking go. Night peeing is not a personality trait. It is not your cute little quirk waking once in a while. Sure, life happens. But if you are up most nights, 1, 2, 3 times, and you barely pee or you pee small amounts and then lie there staring at the ceiling, that is not just how you are. That's a symptom. And my mouth is on the floor that we've been told to just accept it. No, we get curious because chronic night peeing is a system issue and systems can be tuned. Let me lay out the usual suspects in normal person speak. First, fluid timing. If you crush your water at 7 p.m. because you forgot all day, or you're sipping tea or sparkling water on the couch till your show ends, your bladder is like, cool, see you at 2 a.m. Second, caffeine and alcohol. Caffeine is a bladder irritant and a diuretic. Alcohol, too, translation, more urine, more urgency, and lighter sleep. Third, trained habits. Just in case, pees before bed, and at every tiny whisper, train your bladder to settle for small volumes, so the alarm goes off earlier. Fourth, sleep disruption itself. Stress spikes, hot flashes, the dog barks, your partner snores, you wake for that reason, and then your brain runs a quick systems check. Bladder online? Might as well go. Fifth, hormones and tissue changes. Peri and postmenopause shift tissue resilience and bladder sensitivity. So the alarm is touchier at night. Sixth, pelvic floor tension. We just covered this. If you're clenching by day, you're probably clenching by night. And a clenched floor plus a jumpy alarm equals up you get. And yes, sometimes the driver is sleep apnea or snoring, the airway narrows, oxygen dips, your body shoots out a wake-up signal and a hormone that makes you pee more. Wild, I know, but common. Now let's translate that I thought I had to pee moment at 2 a.m. You actually wake because your brain gets pinged. Stress, dream, hot flash, snore, temperature shift. You open your eyes, the nervous system flips on the lights, and the first internal text it sends is, while we're up, check the bladder. And if there's any urine at all, your brain, which now hates risk at night, declares it urgent. You go, you produce a thimble, you crawl back in bed, and accidentally, you've just rehearsed the loop. Do that 4 nights in a row, and your body learns, wake at 2, pee small, repeat. It's not a character flaw, it's conditioning. Here's the kicker. Fractured sleep makes pain and urgency louder. Short nights and middle of the night wake-ups dial up inflammation and crank your pain sensitivity. The more tired you are, the more your pelvic floor guards. The more it guards, the more your bladder screams. The more your bladder screams, the more you wake. That is a loop we can interrupt. You cannot out-Kegel a 2 a.m. adrenaline surge. You calm the surge, retrain the signal, and change the inputs that are yanking the fire alarm. Relief starts with clarity. This is not a life sentence. It's levers. Front load fluids, stop the bladder irritants early, untrain the just in case, and teach your body that nighttime is off duty for the bathroom unless the tank is actually full. We're going to run a simple 2-week experiment together in a minute minimum effective dose. 0 white knuckling to shrink the alarm, protect your sleep, and give you data you can take to your provider if you need more support. For tonight, if you wake and the urge is a whisper, pause. 3 slow, 3, 6, 0 degree breaths. Let your ribs expand, let your belly and sides soften, feel the pelvic floor drop on the exhale. If the wave passes, roll over. If it builds, go no shame. That's how we start flipping the script. You're not broken. You've been trained and you're about to retrain. Let's freaking go. Nobody prepared you for this part. And my mouth is on the floor that we still whisper about it like it's a moral failing. It's not. It's biology. When estrogen dips postpartum, while you're breastfeeding, in perimenopause and menopause, and yes, sometimes with certain meds that dry you out, the tissues in the neighborhood change. The skin at the entrance, that tender ring called the vestibule, the vagina, the urethra, even the first inches of the bladder are all estrogen sensitive. Less estrogen means thinner, drier, less elastic tissue, and a shift in pH that evicts your friendly bacteria. Translation, it can burn, it can tear like a paper cut. Sex can sting even when you're turned on and emotionally there. and your bladder can feel urgent and irritated with or without a true infection. That UTI feeling with negative cultures, tissue and nerve sensitivity can mimic it perfectly. Let's translate tissue health, because you deserve normal person speak. Healthy tissue is plump, well lubricated from the inside, stretchy, with good blood flow and a calm nerve supply. When estrogen is low, the cushion thins, the surface gets fragile, blood flow drops, and those little nerves lie closer to the surface like tripwires. So even light touch can feel like sandpaper. Penetration that used to feel fine now lights you up. And because the urethra sits right next to all of this, it gets cranky too. Hello, urgency, burning after you pee, and that constant there's something there pressure. You are not imagining it. You are feeling it. The tissue is different. And I love you, but we have to bust the biggest myth right here. Just use lube is not the same as treating tissue health. Lube is fantastic for friction. It makes things slide, but it does not rebuild the cushion, restore the pH, or calm those exposed nerves. That's like waxing a car with no engine. Use lube? Absolutely. But don't stop there if the tissue itself needs support. Different tool, different job. So what are the evidence-backed moves you bring to your clinician? Localized therapies. Keyword, localized, meaning they work right in the neighborhood. Low-dose vaginal estrogen comes as a cream, a tiny tablet, or a soft ring. It helps replump the tissue, restore the protective pH, improve lubrication from the inside, and can reduce urgency and that after pee burn. There's also vaginal DHEA for tissue health, and for some women, an oral option called a SERM that targets vaginal tissue. Moisturizers different from lube are used regularly, not just during sex, to hydrate the tissue. Think hyaluronic acid-based products. Ask, can we look at localized options for tissue health and a moisturizer routine? If you're on meds that dry everything, antihistamines, decongestants, some antidepressants, certain birth control or anti-estrogen treatments, say, can we review my meds to reduce dryness if possible? And if pain has trained your pelvic floor to guard pair tissue care with pelvic floor physical therapy to release and retrain the muscles so your brain stops bracing before you even begin, practical add-ons while you line this up. Choose unscented, pH-balanced products or just water for the vulva. Ditch the harsh soaps and wipes that inflame already fragile skin. And yes to plenty of lube during intimacy water or silicone-based, whatever your tissues like. With reapplication without apology, this is comfort and healing, not a performance. Identity reframe. And I want you to tattoo this on your brain. You did not age out of comfort or pleasure. You didn't do anything wrong. Your body changed, and it's asking for updated care. Treat the tissue and the nerves calm down. Treat the tissue and urgency eases. Treat the tissue and sex can be something you look forward to. Again, not something you brace for. You want the facts. You want the science. You want results. This is the game changer you were not told about. Let's freaking go. Here's our rule, and I want you to tattoo it on your frontal lobe. We love the minimum, not the perfect plan. You'll abandon on day 3. The tiniest action you can repeat without thinking, because repeatable is what rewires your body and your brain. So we're going to run a 2-week minimum effective dose sprint together. 3 levers: fluids, irritants, and down training. That's it. No extremes, no new personality. Just small moves that calm the neighborhood and give you data you can bring to care. Fluids first. Sensible hydration. Front-loaded. If you're that person who forgets to drink all day and then chugs a water bottle after dinner, no wonder you're up at 2 a.m. Let's flip it. Drink a glass when you wake. Keep a bottle nearby and aim to get most of your fluids in before late afternoon. Think 2/3 of your day's intake by 4 p.m. Then taper sips with dinner and shut down the constant sipping 2-3 hours before bed. This is not deprivation, it's timing. Your bladder likes a daytime job, not the graveyard shift. And no, you do not need to prove you're hydrated by peeing every 20 minutes. Pale yellow urine is your North Star, not crystal clear at all costs. Caffeine and alcohol, Let's have a reality check without the shame. You don't have to go monk. You do get to run an experiment. For 2 weeks, move caffeine earlier, last cup before noon, and cut your usual amount in half. Track what happens to urgency and night waking. With alcohol, limit to 1 drink, finish it at least 3 hours before bed, and take 2 nights off each week. I am not your warden. I'm your coach. If your symptoms budge, you just found a lever. If they don't, great, you have data and you can stop blaming your latte. Now the nervous system. Down training in 60 seconds, before bed and before sex, sit or lie down, 1 hand on your ribs, inhale through your nose for a slow 4, feel your rib cage widen in all directions, front, sides, back. Exhale like you're sighing out a candle for 6. And imagine the pelvic floor dropping like an elevator to the basement or a hammock softening. Unclench your jaw, soften your belly, 3 to 5 breaths. That's it. You're teaching off, minimum, repeatable, powerful. Sex pain adjustments start now, not when it's fixed. Permission to stop, permission to slow down, more arousal time, like double it. External stimulation first, then anything internal, only if your body says yes. Positions where you control depth on top, side lying, or with a pillow under your hips to change the angle. Lube like it's equipment, not an apology. Use more than you think. Reapply without shame. And if pain shows up, that's information, not a challenge. Pause, breathe, change position, try again later, or not at all. You are not broken. Your body is asking for safer input. And we track like a scientist, not a critic. 2-week symptom log, 60 seconds a day. Jot down fluids timing, caffeine, alcohol, yes, no, and when, any bladder irritants you tried, pain with sex, 0-10, where it was, what position, what helped, daytime urgency scale, nighttime wake-ups, and whether the P was small, medium, large, and any culture results if you got tested. This is not a diary of failure. It's a map. Patterns pop fast when you look for them. You bring that to your clinician, and you sound like the CEO you are. Here's what moves my needle. Here's what doesn't. Here's where I want targeted help. Small targeted changes, hydration timing, irritant experiments, 60 seconds of down training. You will feel shifts. Sleep protects. Urgency softens. Sex stops being a dare. You want the facts. You want the science. You want results. This is the minimum that moves the maximum. Let's freaking go. Advocacy is not a personality. It's a skill. And starting today, you have it. You have done the log. You have levers that moved your symptoms. Now we walk into that office like the CEO of your body, and we set the tone. Here's your opening line. Say it exactly if you want. These symptoms are affecting my sleep and my sex life. I want a plan, not reassurance. Full stop. You just framed the stakes, the impact, and the expectation. And if your voice shakes, that's okay. Courage is not quiet. Courage is clear. Now, specifics, because you want the facts, you want the science, you want results. For recurrent urinary symptoms, you ask, I'd like a urine culture, not just a dipstick. If positive, follow with. Which organism is it? What antibiotics is it sensitive to? And what is our recurrence strategy? If your cultures keep coming back negative, but you feel like you have a UTI anyway, don't let the conversation die there. Say, given negative cultures, can we evaluate non-infectious causes, bladder lining irritation, pelvic floor overactivity, and tissue changes? Can we check a post-void residual to see if I'm emptying fully, review bladder irritants, and discuss local vaginal estrogen if appropriate? Mechanism, not mystery. Plan, not pills on repeat. When does pelvic floor physical therapy belong on your list? Way more often than you've been told. Use this checklist out loud. I have pain with penetration, tampons hurt going in or out. I've got persistent urgency and frequency with tiny Ps, postpartum symptoms that never fully settled, a feeling of pelvic heaviness by the end of the day, or leaks with exercise or sneezing. Any yes? You say, I'd like a referral to pelvic floor physical therapy. This is not fringe. This is first line for a lot of what you're living with. Names to know so you can steer the ship without overwhelm. Urogynecology, Think OB, GYN plus urology specialists in pelvic floor, bladder, and prolapse. Urology, urinary tract specialists. Some focus on women's bladder issues. Pelvic pain specialists, often gynecologists or multidisciplinary clinics that treat pain loops and nerve issues. Vulvovaginal specialists, gynecologists with advanced training in vulvar and vaginal conditions and tissue health. Pelvic floor physical therapy, licensed physical therapists who treat the muscle, nerve, and scar tissue side of the neighborhood. You do not need the perfect door on the first try. You just need a door that opens. Set boundaries around dismissal. And I'm dead serious about this. If the only answer you get is that's normal, or just drink cranberry and relax, you escalate. Calmly, that doesn't address my impact or a mechanism. What's our next step, and who is the right specialist if this isn't your lane? If they can't or won't, second opinion. That is not being difficult. That is self-respect. You can bring notes. You can bring your partner. You can bring your 2-week log and hand it over like the boss you are. Say, please explain the plan in plain language. What are we ruling in, ruling out? What does success look like in 4 weeks? And how do I follow up if this doesn't help? Ask them to write it down. Ask for the portal summary. Insist on clarity, because advocacy is clear symptoms plus clear requests plus the right specialist, and that turns years of suffering into an actual plan. Let's freaking go. Here's the moment I want stamped on your nervous system. You are not broken. You have been undertreated, full stop. We walked through the shame, the whispering, the just live with it, and we replaced it with maps, mechanisms, and moves that change the day you're living in. That weight lifting off your chest right now, that is validation. That is what it feels like when your experience finally makes sense and it's not a character flaw, it's a care plan. So let's future cast your life, because this isn't fantasy. This is a treatment pathway. Imagine you close your eyes at 10:30 and you don't pop awake at 2 a.m. with panic and a thimble of pee. Picture intimacy where you're not bracing, you're not apologizing, you're not negotiating with pain, you are present, and your body says yes because it feels safe. Picture hopping in the car for a day trip and not mentally mapping every bathroom like you're a Secret Service agent. Picture saying yes to a workout class without packing a second pair of leggings just in case. That is not a dream board. That's what happens when you line up tissue care, pelvic down training, smart hydration timing, and the right specialist who treats you like a human, not a nuisance. And I want you to anchor into this identity shift because it is everything. You are the kind of person who wants the facts, you want the science, you want results, and you are allowed to take up space in healthcare. You ask for cultures. You ask for mechanisms. You request pelvic floor PT. You say, I want a plan, not reassurance. And you say it even if your voice shakes. You are not difficult. You are clear. Now we turn relief into a ripple because silence is how undertreatment survives. Send this to your sister who jokes about cranberry juice like it's a personality. Send it to the friend who dreads date night and thinks it's her fault. Drop it in the group chat with the moms who've been leaking since delivery and just buy more pads. Save it for your daughter's future self so she never thinks pain is the price of being a woman. We change culture one permission slip at a time, and you just printed a stack. One next step today, not 10, one. Pick it now. Start the 2-week symptom log tonight, or search for a pelvic floor physical therapist and make the first call, or copy paste the doctor script into your notes app, or move your last caffeine to before noon and set a reminder, or do 60 seconds of bedtime down training and teach your body off. Choose one and do it. When you take that first tiny action, you prove to yourself that relief isn't theoretical, it's happening. You've got the map, you've got the words, you've got the permission. Let's freaking go.